And yes, indeed, from looking at the highlights of the news, making headlines right on the dailies, and of course, what we're following up for you today. Let's just take a pause and just look at in the market. And well, I said, being a Thursday, of course, on AM Live, we'll look at matters to do with business. But then again, we're looking at matters to do with health today in particular, because, you know, a healthy nation is a wealthy nation. So taking care of your health to increase your wealth. Well, and today we are honored to be joined by two guests, I must say, with all the prefix doctors to their name. They're all medical doctors. On my far left, I'm joined by Dr. Wycliffe Kaisha, who's a gastrosurgeon from the University of Nairobi. Wycliffe, thank you so much for being here. And we have also Dr. Subash Gupta, who's a liver transplant surgeon. That's at Mark's Hospital, particularly based in India. So we have the two gentlemen right here. Thank you so much for creating time for us. So today, of course, the discussion will be around, of course, gut diseases, but in particular, we've narrowed down to liver cirrhosis, just trying to look at issues to do with liver diseases in the country, preventable measures, where you can actually seek for medical treatment, and more particularly also on medical tourism. As I mentioned, also we have Dr. Gupta, who comes in from India, and of course there's a lot of exchange programs going on between the two countries into how we can borrow best practice. And you can participate and of course join into the discussion following us online. Of course, we have the hashtag AM Live TV. You can also tweet us at NTV Kenya, and also you can tweet me directly at Laban Cliff, and also feel free to call in. We'll be taking a few calls from yourselves. And of course, if you have any questions from the two doctors, this is actually free consultations to go on with it. So yes, make sure we can actually maximum and get the wealth of information from these two gentlemen. So thank you so much for being here. Wycliffe, I'm going to start with you, Dr. Ari. Just looking at the state of liver diseases in the country, where are we? And of course, being in Nairobi University, you have kind of a general overview on where we are at in liver diseases in Kenya.
So thank you very much. I work at the tertiary institution, that's Kenyatta National Hospital, and mostly patients with liver disease come to the liver clinic, and most of them have a background of liver cirrhosis due to various causes. Mostly we have hepatitis B and a good number of alcohol-related diseases, and some people have what we call non-alcoholic steatohepatitis, which is related to obesity and metabolic syndrome. In this situation, mostly the liver cells are destroyed and replaced by tissues that can't function, and you know there are certain functions of the liver which cannot be done by any other organ, and as such they go into liver failure. Hepatitis B is quite prevalent in this country. Probably compared to other countries, hepatitis C might be more, but hepatitis B is a big problem. Most of these patients would generally have certain complications. Some people come vomiting blood, others abdomen swell because there's fluid accumulating, and probably they get treatment directed at these problems to try and prevent progression of the disease. The hepatitis B can be treated by antiviral medications, actually quite successful in most situations. But in a few number, a good percentage, this liver disease progresses probably because of delay in treatment or the time of presentation, whereby therefore common medical treatments cannot be done and might progress to liver failure, which requires replacement of the liver. And currently the only treatment that works to replace an unfunctioning liver is liver transplantation. So most of the other treatments like treating the varices when they're bleeding, various complications from liver diseases will be available, but probably we still are not at the stage of giving them the final treatment, the chain when they reach there, which is a liver transplant.
Very well, Dr. Kaisha. I'm just going to kind of come back to you, and of course we can break it down. And of course, just is there any research that has been done on a general scale, just looking at kind of the liver disease situation in the country, be both at University of Nairobi or the Kenyatta National Hospital?
Yeah, there's a lot of research, and I think in the formative years, the professors in the medical liver clinic actually the ones who clearly showed that we had a big problem with the hepatitis B. we also have a big problem with alcohol. I think that has been a problem in society that we've been fighting, and I think those are the two major leading causes of problems of liver disease in our society. And you can see these are easily preventable and treatable. Of course, there are other inherited disorders that can give liver disease, but these are not as many in the adult as possible. What I'm talking about really is the adult situation. I'm not talking about the children, because some are born with some inborn errors of functioning of the liver. That's a different kind of problem.
All right, we're going to come back to that, of course, on the issues to do with the kind of the causes and looking at the effects of alcohol on liver, and especially on liver transplant. But Dr. Gupta, I just want to ask you, from where you sit, is it a similar situation in India, and what's the situation back there?
Yes, if you look at other conditions of death within a country, then liver-related diseases are probably the most important cause of death, in the sense that the others, there have been a lot of stride made in looking after patients with ischemic heart disease, even in cancer treatment. But because liver disease treatment ultimately requires transplantation, which is such a complex operation, that in our own country, the number of people who suffer from liver disease is about 200,000 people who die from liver disease annually. And only about 2,000 of these people can be saved by liver transplantation. The reason is that liver transplant is a very complex surgery and is not done in many places. And also, of course, liver disease is a slow disease, in the sense that it affects you over a period of time, and they think that they've been okay, they've managed with liver disease for a few years, they can go on forever. But that's not true. At some point, if liver transplantation is not done, then they'll have an untimely death. So in our own country, we've been instrumental in bringing about this new form of treatment, because that was in the past limited to few countries in the West. And that has been possible because we've developed living-related liver transplantation, where although all of us have only one liver, but technology and research has developed so much that we can remove half the liver and the remaining liver regenerates and also grows in the patient in whom it's transplanted. And therefore, it's a very successful form of treatment.
Great, you just touched on that, but let's really quickly just move into that transplant. Dr. Kaisha, you mentioned something that's very interesting, that as a country we haven't quite gone into the in-depth level of actually ensuring that we can fully have liver transplant being operated in the country. Right?
Yes, I think medical progress has been going on around the world, and liver transplant is, in as far as medical technologies, is probably fairly recent, and successes have been improving, because in the 70s was seen like an experimental kind of treatment. But in the recent past, with better immunosuppression, because remember, this is a tissue you are borrowing from somebody else to give to another person, therefore the immune system is always ready to destroy it. So plus the anatomy of the liver is complex, with a lot of vessels and ducts that need to be connected, and then again you need to get the liver from somebody else. And as Professor has mentioned it, you could get the liver from somebody who is probably brain dead or the heart is dead, and then while there's still a bit of circulation, and then you transplant the liver, or borrow half from somebody who is related to it. So it's a whole complex kind of scenario, and therefore Kenya has been doing baby steps in various kind of medical fields. Now, where are we in liver transplant? I worked with Dr. Gupta around 2010-11 in his transplant unit in Delhi, and he's been kind enough to train two or three other surgeons in our unit and other members of staff, and the hospital has an ambitious program, probably in 2 to 3 years, to have liver transplant going on. So
that's within Kenya National Hospital.
That's within Kenya National Hospital. And remember, nothing really happens on its own without somebody investing in it. So we actually, the forerunners who are trying to run with this program, to get it where we are. You'll definitely agree more developed countries and richer countries will always have better healthcare, while others will have to take steps to catch up with what they are doing, because it really needs a lot of investment and money and support. Even if you have a liver transplant surgeon and you don't have other supportive health workers, the whole gamut of people, it won't work. So we basically now at the stage of training and creating an environment that will allow it to be done safely, because there's also no need of borrowing half a liver from somebody else to give the other person, and the person donating who is actually a normal person getting harmed, or probably also the person being transplanted to dying because maybe the whole process we didn't get it right. So we probably are at training and at investing in facilities, because if you look at the whole facilities around a liver transplant, I call it like an industry around the support of just one transplant.
So is there particularly maybe a cost estimate on to kind of, how much would be required to particularly Kenya for the country to have a fully fledged liver transplant facility?
I can't give you a figure. Probably I could give you an idea of what the cost of transplanting a patient, for example, around America, roughly, or Europe. It costs you close to $1 million.
Wow.
Yeah, close to $1 million for the whole process, because there are many experts. There's liver transplant, ICU, there's also the blood transfusion products that blood products that you need to support the whole process. So it's really actually close to transplant surgery and transplant science. Actually, the most complex part of surgery in terms of all surgical disciplines. So probably you can see that even as you come to that $1 million, there are other costs that you can talk about. I'm not really talking about costs only. Talk about technology. That you need to invest in this technology. I know in this country still there's a competition of health funds for primary health care and even satisfying other needs like maternal health care, safe delivery. So by the time we are asking for some of these funds to go into a super specialist kind of care, then there's a bit of competition for resources, and basically government would need to invest in this, because I don't think we've reached a point where maybe for private providers might not be able to make a profit as it were at this moment. So those are the impediments, but we're working very hard at it.
Just for viewers, I mean, you mentioned $1 million. I mean, to an estimate, it's about 100 million Kenyan shillings. Looking at it, it's quite expensive, I should say. Yes. I mean, and it's not really a procedure that one would go through well, even if it's still a medical insurance that they have. But Dr. Gupta, let's just look at it. And as Kaisha mentioned, that of course there's a whole facet to it. You're looking at the skill set, you're looking at the technology, you're looking at the investment into it. From India, I think maybe just borrowing in from a success story that you have your own training facility. And is Kenya the only country that you're looking towards in terms of just ensuring that we develop our skill set?
Yeah, no, a lot of people come to us from all over the world. In fact, we have trainees from Brazil, from Singapore, from Malaysia, from many African countries, from countries around the corner. But going back to Dr. Kaisha's point, obviously investment is huge. And therefore it cannot be done in every hospital. But what can be done, and I'll tell you how we did it in the beginning in '98 when I came back from UK, and it seemed that liver transplant was going to be non-starter. Now, liver transplant is an operation for one patient, but at the same time, all the other aspects of liver transplantation will actually upgrade your hospital to a very high level. So not all the investment can actually be attributed to liver transplantation. For example, you can have your lab services, investment can be made into lab services so that there's better diagnostic facility. Investment can be made into blood bank facilities so that the blood bank is serving better. Investment can be made into anesthesia department so that they can perform better. Investment can be made into radiology department so they perform better. Investment can be made into gastroenterology. So not all burden should come on Dr. Kaisha that, oh, we put in so much money for you and you produced nothing. But overall, if your hospital is doing liver transplantation, the standard of that hospital goes up enormously. And this is what we did. When I came back in '98 to my hospital, they said that it's a huge investment, we cannot help. So I convinced them that you don't need to invest on me, but you can upgrade your existing specialties, let them improve, and let them all share the cost of the investment that is needed. And as a result, all other related departments, for example, gastroenterology improved substantially, blood bank services improved, microbiology improved enormously. So that's how we have to look at it. You should not look at it as an investment for liver transplantation. In fact, most of the investment that is needed in liver transplant, and I'm sure Dr. Kaisha already has, because you cannot do complex liver surgery, even if you didn't do liver transplantation, without a basic Cusa machine or retractors and micro-instruments. So really, if you look at it as a sort of standalone liver transplant center, then the investment is huge. But if you invest in every area of the hospital so that their facilities are upgraded and you can generate more revenue from there, then you are in a better position to start liver transplantation.
Great. Dr. Kaisha mentioned about 2 to 3 years when perhaps the country can be able to have a fully fledged facility, but still staying with Dr. Gupta, from where you sit, of course, I'm sure there's been a lot of patients traveling over to India, and maybe you've attended to some of them. In your view, what especially is kind of the inhibitors, or should I say inhibitors to treatment of liver disease, especially in transplant?
I think the main inhibitors generally, most people still do not accept, doctors and I'm referring to here, don't expect that liver transplantation is a successful form of treatment. In fact, if Dr. Kaisha had not visited us in 2010, he perhaps also would have thought that liver transplantation is a very experimental surgery. But the way the surgery is difficult, but subsequently the body can accept the liver in a year's time or 2 years' time, you enter into a tolerant phase, so that the medicine that is needed to deal with rejection is much less. So after 1 or 2 years, many of these patients look completely normal. In fact, there's a famous football player, Abdal in France, who's had a liver transplantation and playing football.
Eric Abidal.
Yeah. So that's how liver transplantation, it's a gift of life, as we say. And the main impediment is, number one, that people don't think it's a successful operation. Number two, they think it's a very expensive operation. Dr. Kaisha talked about it costing $1 million in the US and UK, but in India we have reduced the cost to $30,000 US, which is quite affordable to as I see it. But then the main impediment then, of course, is lack of organs, because even now, although research is going on in a big way to get organs from animals, from labs, from 3D printers, but the main source of organs are still humans. And in that way, I mean, it's important that cadaveric donation should be promoted, which is the people who have an accident, who have to bleed inside the brain, they are on a ventilator, and if their family were willing to consent, then not only liver transplantation, but kidney transplantation, heart transplantation, lung transplantation, intestine transplantation, corneal transplantation, so many lives can be saved if just the family were willing to donate the organs of the near and dear one who's met with a tragic accident.
All right, Dr. Gupta, I want to still stay with you. Just kind of break it down for us. You know, you're in your theater and you've had this patient who's traveled overseas and they've come to see you. What goes on? What is the procedure from the beginning of the transplant to the end of it?
Usually somebody will write to us directly, and then saying that this is my problem. Then we look at their reports, and in many countries, because we end up serving many countries, we have friends and students all over the world. So we'll ask them to go and meet, so for example, Dr. Kaisha, and see whether he really is a transplant candidate or not. Because if someone is drinking day in and day out, has not tried abstinence at all, then this would be pointless transplanting them. People who've had, say, hepatitis B and hepatitis C, which are the other two common causes for liver disease, they should have been treated at least in the beginning before they think of liver transplantation. These are small details which a colleague sitting here should be able to tell the patient, no, first you should try this. So once that has been confirmed, then we request them that if there's a family member of the correct blood group who's between 18 to 55 years of age, and they are willing to donate part of the liver. Donation now is quite safe. In the past, it was, of course, a very hazardous operation, but now with development in scale, development in imaging and theater techniques, that it's a very safe operation. So you can remove quite a bit of the liver without any blood loss. So, but for that, you need to have a lot of imaging, and that should be done even before the patient thinks of coming to us, so that the worst thing to happen for a patient, say from Kenya, to come to us and then their condition deteriorates and there's no suitable donor. Because by law, you can only do transplants from related people. You cannot do it, you cannot take livers from unrelated persons at all. So by the time they come to us, all this basic groundwork has been done. So and then we can quickly get permission from the hospital and go on with transplantation.
All right, great. And just to delve deeper, I'm told there's a call on the line, and we have Richard. Richard, if you can hear us, just kindly pose your question to the doctors.
Yeah, in fact, I'm Richard from Kisii.
Go ahead, Richard.
Dr. In fact, my main concern is it possible to get the liver? And if it is to be obtained, don't you see we are creating some room? Because I don't see the possibility of it being obtained easily from live individuals.
You asked whether it's difficult to get a liver from a living individual?
Yeah, you see, because you have said that it can be possible that we can have from a living individual so that it can be transplanted as it regenerates.
Yeah, well, that's why it is an expert kind of work, an expert's work. It's not impossible because although you might have heard us say the liver looks like one organ, it actually has two parts, a clear right and left part, and therefore it can be split successfully into an nearly equal right and left, and therefore a good amount of one side, usually we pick the right side, can be transferred to the person who needs the liver. Of course, the person who needs the liver will have to have their basically almost dead liver removed, and then they are given this other liver. Of course, it's easier said, but it's a technical operation, and that's why it's done in specialist centers. It's not an impossible operation. It's actually an operation that's done daily, and even it has reached a point where we're able to do it by keyhole surgery, and therefore even the person donating comes back having recovered quickly and with very little signs of having surgery on them.
Break it down. What do you mean by keyhole surgery?
I think you need me on this program another day
Sure.
to educate you on
No,
keyhole surgery.
I would feel, because
Yeah.
I know in the medical terms, definitely there are very many technical terms, but I'm just trying to look at it, break it down for the general public.
We call it laparoscopy, and it's going towards robotic surgery in the abdomen, but for the general population we call it keyhole, because as opposed to making a huge cut about 15-20 centimeters on the abdomen to get into the abdomen to do the surgery, we're able to make cuts as small as 10 millimeters and 5 millimeters on the abdomen, then using specialized equipment to get into the abdominal space and work there. So I want to reassure him, although it's a technical expert operation, technology has reached where it's done safely and in almost a routine manner.
Wow, Dr. Kaisha, thanks so much. Richard, I hope from calling from Kisii, I hope your question has been answered. And of course, just still staying with Dr. Kaisha, yes, you mean, and I like the focus that you actually have, which is, of course, we're going to get there. There's still a lot of research, still a lot of training that's going to take place. But before we take a break at the top of the hour, let me just quickly now go into these causes. And of course, I know what is top on people's minds is the issues to do with excessive drinking.
Yes.
So how much is too much?
It varies from individual to individual. How you react to drinking sometimes even depends on how well your body breaks alcohol and clears it. Definitely the first step of alcohol breakdown is to make a toxin we call acetaldehyde, and a lot of people make it remains in the tissues and keeps destroying liver among other tissues. There are a lot of genetics involved, but generally it's impossible to predict and say take a glass or two. So as part of health, generally alcohol tends to be harmful to health, but you can't say whether it's a glass or two, how much per day. it's impossible. There are a lot of guidelines that have come all over the time. They've been revised, right, center, and left, because it's difficult to pick who will react in a certain way. Even if it's not destroying your liver, it might be destroying another organ. If for other people, if it's not destroying another organ, it's destroying the liver. So it's really pertinent, if possible, to avoid things like alcohol, cigarette smoking. And some people even come with early alcoholic-related liver disease, and sometimes just stopping the alcohol is enough to reverse the damage going in, because the liver is quite a resilient organ. It's able to repair itself and regenerate itself. But there's a reach at a point, if completely damaged, then there's no going back. And you can't even say which type of alcohol.
Yeah.
Yeah, there are some important points about alcohol. One is that most people think that beer doesn't have much alcohol, but actually beer drinkers are probably at a bigger disadvantage, because beer you drink by bottles and cans, and even if you take a conservative estimate that it has 5% alcohol, so the can of a beer will actually more than a peg of whiskey in terms of alcohol. So that's the important thing to know, is that the absolute amount of alcohol is important, not the type that you're drinking. So if you think that beer is safe, you're mistaken. You actually drink beer by cans. So a rough calculation will tell you that a 550 ml can will probably have 35 grams of alcohol minimum, whereas a peg of whiskey will have only about 30 ml peg would have just about 12 grams of alcohol. So that's a very important point to know. The second thing is that if you are in habit of drinking, then perhaps you should get your liver test done twice a year. And if your enzymes are raised, then you should quit for a while. Maybe you can see a specialist. Nowadays we measure liver stiffness, and if your liver is stiff, then it's much more likely to be damaged by alcohol, and therefore if your liver is stiff, then and that's a simple ultrasound method of testing the stiffness of the liver. So if you test the stiffness of the liver, and then you should really be not be drinking at all. And the third important point, which is...
Sorry, is that a procedure that can be done in the country?
Yes.
All right, great.
The third important point that is related to alcohol and liver disease is people who are diabetics. And people who are diabetics, in general, perhaps are better off not drinking at all, because diabetes now recognized to be an important cause of liver fibrosis, and coupled with drinking on a big amount, then your liver is going to pack up very quickly. So I don't know how big a problem diabetes is in Kenya, but in our country, in India, diabetes is a big problem. And so people who are diabetics and drinking, they have much faster progression of their liver disease. And the final point, as far as alcohol and liver disease concerned, is that what we say, if you stay within 21 units in a week, and 1 unit is about 10 grams, then it's very, very unlikely that you'll ever have liver disease related to alcohol.
Let's do the grams in terms of percentage alcohol. Is it 21 units? This is just looking at the pint levels. Yeah.
So 1 unit is 10 grams of alcohol.
Okay. Yes.
So if you have a peg of whiskey, that would be about 1.2 units. So, and also interestingly, females in our country have now drink alcohol much more than the male people, and the female livers are not able to tolerate as well as the male liver. So in that the ceiling is 14 units every week. So if moment you cross that ceiling, then you expose yourself to liver disease. But of course, we all know that many people, as Dr. Kaisha was saying, can drink a lot, and their genetic conditions, and they metabolize faster, and they will not have any problem. But by and large, if you stay, for a male, if you stay within 21 units in a week, and a female 14 units in a week, that means, which roughly means 2 to 3 drinks every day, not more than that.
2 to 3 drinks every single day. Wow, that's quite high. That's quite high. But you, Dr. Kaisha, you actually, I'm sure you understand me when I mean that, you know, especially as a country, of course, this is, you know, it's also a traditional way. You know, people want to enjoy a traditional drink and want to enjoy their beer, they want to enjoy their local brew. So then, and you, in your statement, you said that it isn't quite being estimated, like, you know, this is the level that you'll say now, at this level, then you'll now be able to...
what you need to understand about medical research, the recommendation usually apply to the majority of the people. We talk about standard deviations in research. So what Dr. Gupta is talking about generally applies to most people when he says about 2 units of alcohol per day can be almost on the safe age of drinking. And of course, what my friends then think, they can add up all the units and drink at them at one sitting over the weekend. Yes. Binge drinking is even more harmful. So it's not possible to give each and everyone their limit, but that's generally what applies to society. But of course, selected people, you've had like diabetes people, or people whose liver is already undergoing damage from other causes, then if you add in alcohol, even worsen it. Yeah, so we just need to be reasonable in your drinking. Probably even have drinking holidays, meaning breaks, not going to drink and all, but having breaks in between, especially if already we are showing some damage to your liver going on, and especially even medication for other causes, sometimes plus alcohol will even worsen the damage there. So the best thing is to try and avoid, but if not, then it has to be very moderate drinking, which probably
which is 2 to 3 glasses per day.
that was beer, 2 to 3 units, yes. Or a glass of wine, okay. Or 2 thoughts of whiskey or cognac, whichever you like. Yeah.
But those who drink fast-paced slowly.
Doesn't really, but some will argue that, well, indeed, that as much as they'll also, engage in drinking, they'll still exercise and they'll still engage into other health benefits, although they will still eat healthy, have a healthy diet for that matter.
Yeah, well, any effort towards good health will always help, but because you think you'll exercise, then you'll take something harmful on the other side. It is impossible to predict how they will interact. So a health-conscious person who is exercising, eating a good diet, should even be further more conscious and even try and regulate their alcohol intake. And a very important point was said that probably if you take alcohol, whatever amount, probably you should have a regular medical, where you look at your liver function test, and it's a cheap test in the lab, and have a specialist interpret it for you, and probably it's simple. If the enzymes are going up, stop taking alcohol.
That's a very important point, because liver is very damage is reversible, so you don't really. There's an important point about alcohol in terms of nutrition, because a lot of alcoholic people will end up only drinking alcohol and neglect their meals. So I think meals should not be neglected. Timely meals should be taken, even if you're drinking a lot. Make sure that you don't, your calories and your intake just doesn't come from alcohol. It comes from a balanced diet. Because one of the problems with alcoholic patients suffer is malnutrition. They end up with major vitamin deficiencies, and therefore that may actually worsen the problem.
But even as you talk about alcohol, we need to remember in our society an important cause called Hepatitis B. Mm-hmm. Now, Hepatitis B is one of those simple viral infections to prevent, because there's effective vaccination. And I know for the last 5 or so years, the childhood vaccination program has included Hepatitis B. And a lot of people who are potentially exposed to Hepatitis B should have this vaccination. Healthcare workers, laboratory workers, commercial sex workers, and in other situation, people with multiple partners should probably have Hepatitis B vaccination that can easily prevent, because this is what happens. Hepatitis B infection damages the liver, you get into liver cirrhosis, you can go into liver failure. Liver cirrhosis can also lead to cancer of the liver. That's another thing we need to important point we need to understand. Yeah. Once you have cirrhosis, then you can go into cancer of the liver, whether it's from alcohol or hepatitis. Yet hepatitis B is very easily preventable in our society.
There's a very important point about hepatitis B, and that's what we did in our country. All women who are pregnant must have a surface antigen test in them. And if they deliver a baby, then the child must be vaccinated as soon after birth. And because when you get hepatitis B infection as a child, then the body doesn't clear it at all. Whereas if you get it as an adult, then 95% of the time your hepatitis B infection will be cleared by the body's immune system. Mm-hmm. So it's the children and they then end up as being carriers, and they're the ones who keep spreading it to others.
All right. And a very good morning to you. It's exactly 5 minutes past 7 o'clock, coming to you live from the Nation Center. My name is Laban Cliff Onserio. Just today looking at matters to do with your health. As we said, of course, on the Thursdays, we normally have the special features on in the market. But again, we quite feel that your health is your wealth. And of course, a healthy nation is a wealthy nation. And today we're particularly focusing on a liver transplant. And shall I say that you're actually benefiting from free consultation from our doctors right here, both from Kenya and from India. With me, I have Dr. Subash Gupta from India and Dr. Wycliffe Kaisha right here from the Kenyatta National Hospital. Thank you, gentlemen, for still staying with us. Of course, now we'll just be kind of taking it home and just looking at, for a Kenyan who's watching us, and especially even for somebody who's just looking towards accessing this care, and maybe they have the condition, but maybe the costs are inhibiting for them. I think, what would be your advice? The first one, Dr. Kaisha.
Well, I know currently with progress made by the National Health Insurance Fund, they're also assisting patients in various situations. We know very well operations like kidney transplant are being done locally, so there's good capacity for that. But liver transplant, we agreed we're in the process of going forward. So probably they would have to look at other jurisdictions where this transplant would be available. I know the work Dr. Gupta does, and in fact, I think maybe the year before they did the highest number of transplants in the world at the institution. So we collaborate with them, and therefore are able to consult with him and see suitable ways in which to assist these patients at a probably cost-effective way in terms of referring them to have the transplant done. And he told you the process where you need a donor, because you will not leave Kenya to India for a liver transplant without going with somebody to donate for you a liver. Plus the cost involved, if you compare it with Europe, then India is quite a drop compared to what the other places will be. And the other places also, they use citizens who are dead, and therefore a lot of who have had accidents and have to donate, and a lot of countries don't allow their citizens to directly donate to foreigners. Mm-hmm. So you have to be aware, because I know several patients who've actually taken the journey to India without good advice, and they've gone, they have no donor, and probably they have died or deteriorated, and probably it has really caused a lot of tension. So we try and collaborate, and therefore you need to get to a doctor who is familiar with the liver transplantation and who is in contact with an institution that's able to do liver transplantation to get you through the initial process. Most of the things can be done here before you take that journey to go and have the liver transplant done.
Is it a complication, perhaps? Maybe I'm just looking at, the law doesn't require that you have a transplant from a non-relative, but at the same time, you have cases of people who have written and said that they can actually have their liver donated to anyone.
So if somebody has written, this means they are able to donate. Mm-hmm. That is when they are not able to live anymore. Let's say you've been in a bad accident and you're brain dead, or there's also donation after cardiac death. That you can donate to anyone, but usually restricted to the people in the country. Now, to prevent commercialism, you see somebody with money who has their liver failing going to buy someone else to donate them, they try to make the guidelines very strict that a living related person is the one, so that donation is supposed to be an altruistic act of volunteer, not where you can actually buy somebody. You see it in newspapers. Mm-hmm. I can sell my kidney for 1 million to pay fees, whatever, even in the country currently, people advertising. So that's kind of thing to prevent it becoming a commercial. That just remains a purely medical kind of thing.
Oh, so stay with
that's
that.
Why they try to outlaw living donation, where the donor is alive to an unrelated person.
All right, so stay with that, Dr. Gupta. I'm going to come to you shortly. I'm told there's a call on the line from Khalifa. Cynthia, if you can hear, just your question to the panel, please. Cynthia, your question to the panel, please.
Hello, my husband was diagnosed with hepatitis A. Hello?
Yes, please go ahead.
He was diagnosed with hepatitis A.
Uh-huh.
His symptoms were itchiness of the skin and yellow eyes.
Uh-huh.
After that, he was told it is a self-eliminating disease and it can heal on its own.
Yes.
Now, does he have to use any medicine or it will clear on its own and maybe after 6 weeks to go for a test?
All right, thank you, Cynthia. I'm going to ask Dr. Gupta to respond to that.
This is a very important point nowadays, hepatitis A, because in the young, in our country, what used to happen was that most young people were exposed to hepatitis A, and they would then subsequently develop immunity and nothing further needed to be done. But what is happening nowadays is that as long as the child is at home, they are in a protected environment, and the parents are looking after what they're eating, what they're drinking, and therefore what has happened now that hepatitis A is presenting at a later age. So it's the time when the children go to school, to hostels and colleges, and they're a little bit less careful with the water they drink or the food they eat. And therefore it's important that perhaps there may be a rethink about hepatitis A vaccine, because there is a very effective vaccine for hepatitis A. And we see many of these young people who lived in the protected environment of their home, and they go to hostels sort of out of the city and end up with hepatitis A. By and large, it is a very benign condition. Most of patients will recover completely. But in one situation where hepatitis A can turn into what we call fulminant liver failure, that means you have hepatitis A infection and the liver will recover, but during that process where the liver is damaged, you can get brain swelling, and if you get brain swelling, you become unconscious. And therefore it is important that we have a rethink on how the children, they should be taught about that when they're going to the hostel, they should continue to take care of the water they drink and the food they take, so that they don't develop this completely preventable condition.
Why is it particularly to the students who are maybe, is it maybe that environment, or?
Because at home, the parents, at least in India, are very careful what the child eats and drinks. And when they're out with their friends, they may drink water from a source which is contaminated, or food which is undercooked and not cooked fully, and then they end up with hepatitis A at a much later date. So there's a changing kind of, by the time children are by the age of 2 years, most of children in the past would have been exposed to hepatitis A, and the body would have cleared it, and subsequently they cannot get hepatitis A. But these children nowadays, from parents, because there's a tendency, at least in our country, to have smaller and smaller families. There are only 1 or 2 children. Their sort of complete attention of the parents is on them. And these children, when they get older, leave home, go to the hostels, they're not so careful about what they drink, or where they drink from, or they eat uncooked food, and they end up with hepatitis A. And we have had many patients who, what would be normally a very benign condition, harmless condition, all you need to do is rest and the body will get rid of the virus. They end up with liver failure.
All right. Dr. Kaisha, you're going to take on this question. But just really quickly before you take this call, what's the average age of the patients who come to see you?
In terms of?
Mainly, especially of liver diseases.
Mostly they'll be in 40s in this country, in their 40s.
40s?
Yeah.
All right, great. We're going to come to that. We have a call on the line. So Alex is on the line. Alex, your question to the doctors, please.
Hello, my name is Eric.
Yes, Alex, calling from Tana River. Please go ahead.
Okay, my question is...
Yes.
Okay, now that, we are talking about liver transplant.
Yes, please.
Okay, and we know Kenyans, we have not developed even a law which is very consistent about matters to do with transplant, because I believe matters to do with liver transplant must mean somebody must be dead or something, because I have never seen a person donate a liver like that when he's alive. So my question is, that challenge about the legal challenge about liver transplant and the donation part of it. So if we don't have that guideline for that, why should I even go to be checked that I have a problem to do with something like liver and something that I cannot even be treated, and there are no clear guidelines for that. I would wish the doctors to say how are they addressing that kind of lowers.
All right. Thank you, Alex. Calling from Tenerife. I think Dr. Kaisha maybe can respond to that. I think his key worry is mainly on the legislative aspect, especially in liver transplants.
Yeah, so you know, we've had a huge legislative agenda since 2010 when the constitution was changed. And I think maybe yesterday or the day before, the president just signed the new health bill. So I think from the health bill now, other subsidiary legislation will come in. And there's been a task force working on laws pertaining to transplantation. We already have a kidney transplant program going on, so we already have a bit of a legal framework, but we want to expand this to even include donation after brain death. That will even expand the pool of donors, because actually beyond even technology capacity to do transplant, the source of the organ is also a big impediment. Dr. Gupta already mentioned it. So the legal framework, we're also running with it as we work out on capacity.
Is there like a technical expertise? Maybe if you're targeting that 2 to 3 years, I mean, I don't know, maybe lawyers or seriously legal practitioners who are also assisting in developing of that, I should say, institution in what you focus on?
Yeah, well, we work with the people from the Ministry of Health and the Attorney General's office. They will always second people to work with us. Of course, they also usually need to do a lot of research around it, because they also are meeting something new with new challenges. But it's not difficult. If somebody else has invented a wheel that works, all you need to do is to try and match it to your terrain. So we can still borrow legislation from other jurisdictions that have worked and have seen the problems and solve them appropriately.
All right.
Yeah.
Maybe just for the benefit of our viewers, the two doctors, Dr. Kaisha and Dr. Gupta, come to us courtesy of a Pathway International, of course, who are dealing particularly in this field, of course, in other fields, in looking at medical tourism and, of course, assisting patients to seek medical assistance in India and, of course, vice versa, because it's kind of an exchange that is also going on here in terms of technical expertise. But Dr. Gupta, I also want to just talk particularly about your institution, as Dr. Kaisha mentioned, that you actually the world's leading actually kidney transplant in India.
Liver transplant.
Liver transplant.
Yeah. We were one of the pioneers in liver transplantation in our country, and in fact in '98 this was an operation not done at all, and over the years with sort of great effort we managed to make it a very relatively simple operation. It can never be a simple operation, but it's become a very smooth operation. We've trained a huge number of people, not only within the country, but also outside the country. And also there have been major advances in understanding liver anatomy and developments in technology so that you can cut through the liver without losing blood. That was the main concern. Anytime anyone did a liver surgery, that the blood loss can be enormous. So as a result of all this, liver transplantation has become routine, and we end up not only serving people from within our own country, but we get patients from all over the world. And we have a collaborative, at the current moment we have collaborative work with the government of Kazakhstan, where we've trained their doctors and they now are doing transplants on their own. So it took 2 years. Our team used to go and help them in the beginning, and then there's a period of overlap, and now they're completely doing it on their own. Similarly, we are doing this for Pakistan, and in the future the plan is to help an African country, which is Zimbabwe, and the government is tied up with us to help them develop this liver transplant technology. In the end, if there is a mentor, as I say, then this operation can be done quite successfully. And any country, if the administration of the hospital is a little bit keen, they must be motivated to get transplant done in their hospital, then it can be done quite successfully and easily.
When you mention a mentor, what exactly?
Mentor means that this is a situation where when you transplant an organ into someone where the tissues are different, then not only the technical part of the operation is important, but other factors such as immunological reaction to the organ. That means the body is going to react in a violent way. Then, of course, because you are giving medicine which will impair the immunity, so you will get all sorts of infections. So infections that are not normally cleared by the body become important. And sometimes the pattern cannot be recognized by a new team. So if you have someone whom you know well, and you just send him the blood picture. Nowadays it's so simple. You can just take a WhatsApp video, or you can send the blood test, and someone sitting far away can guide you and tell you, no, this is not rejection, this is infection, or this is technical complication, and therefore otherwise you'll end up doing a whole battery of tests every day to find out what is going wrong with the patient. So if you have someone who's willing to help you in the beginning, yes, till you develop experience of your own, then that helps a lot. And this is what we do very routinely with our collaborative programs in Kazakhstan and Pakistan. Once the operation is done, they send us the flow sheet, and we keep guiding them that what should be done next. And that makes it a very smooth operation. So sitting from far, so the operation part, which is the technical part, but the recovery part, you help them recover on their own by interacting on a daily basis.
All right, Dr. Kaisha, this is the new age thinking, and the new age seeking for medical assistance, I should say, in terms of leveraging on the technology bit.
Yes. We do that quite often with the different collaborative teams, including Dr. Gupta's team. Even there are times you can get an image of a patient, and medicine or treatment not being so straightforward, there are usually different opinions. Because they actually have one problem that can be treated in 3 ways, and different people can have different opinions. And there are a lot of times we discuss using various technological media. You can upload material on the internet, give somebody a password, they look at it, they give you a view, you discuss, and decide the way forward. So this is something that's going on. There are video conferences, there are multidisciplinary teams, there's email, WhatsApp, everything can be done.
I think one thing I like from is that keyhole laparoscopy is,
yes,
as you said, which is actually quite interesting. It is taking place, and especially if you mentioned about the liver, and knowing that it's actually quite a big organ, I should say, maybe in a layman's perspective, but not maybe different from your perspective.
Yeah.
But I know you don't work for them, but please talk to us about Pathway International. I know you've interacted with them. It's also a new age kind of thinking where patients will actually reach out to a firm such as Pathway and ensure that they can actually seek medical assistance further afield.
Let me be very clear. I don't work for Pathway.
From a very analytical perspective, yes.
I know the medical tourism companies are many in the country, and they facilitate patient transport from Kenya to various places, especially when maybe the service is missing. Although, of course, some are unethical, and sometimes they send patients when the service is available, and some even send patients when nothing can be done. And in fact, it's a very sad situation. We probably need legislation to really look at this problem. But what I know, and I can talk about with authority, is the work done by Dr. Gupta and his team. And I want to say their work is ethical, because when they get a patient who they can't do anything about it, they will not take the patient. I know people who are able to send patients to India when nothing can be done. So, and that's why we came with him, because probably he would discuss with me or other people who have the patient and say, yes, this we can help, this we can't help. But medical tourism companies will be there, and I think they'll continue growing, and all they need to do is to do ethical work, and so that whoever whom a service is not available here and it is available somewhere, it's a very good way, because they can send a patient to where the service is available. But we still need a bit of a legislative framework to ensure the correct patient goes, and the one who doesn't need to go shouldn't go and stays around. And beyond that, what people also don't need to realize, there's even inward medical tourism. The patients also come from neighboring countries,
Oh, you should
and
mention,
even
by the way,
from Europe to Kenya also, seeking medical services. As recent as this week, I had like 3 foreign patients who also come in, some on their own, some by medical tourism company. So it's not something to be shunned upon, but it's something that needs a good framework to ensure that good practices like what Dr. Gupta does are supported, but the people who do very unethical things are also exposed.
True. And I like what Dr. Gupta said actually earlier, that before he actually accepts a patient, they will actually cross-check with some of the partner doctors and such as yourselves in the country. Let's take a quick call. I'm told Evelyn is on the line. Evelyn?
Yes, good morning.
Good morning to you.
Yeah, my name is Evelyn from Umoja.
Yes, please.
Yeah, I wanted to ask a question. Yeah, I've been suffering from gas, acid burning my throat, my stomach. So I was just worried. Can it lead to a liver damage? Because most of the time I take rabeprazole, omeprazole, but the acid is too much. Sometimes it goes through my neck, feeling pain. And I was told that there's a valve that is loose, is supposed to be operated so that it can be tightened. So I wanted to know if it can lead to the liver damage.
Dr. Kaisha, do you want to ask maybe further questions into that?
Yeah, I think at the end when she said she needs the tightening, I have already worked out she's seen an expert. Probably just out of my head, I'm thinking she has a reflux where acid is coming from the stomach into the food pipe, and sometimes it burns the food pipe. But if she needs to see a gastrophysician, probably she'll be given proton pump inhibitors to try and treat the lower esophageal, the burning of the food pipe. Sometimes if that works and the patient doesn't want to prolong using the medication, then there's a surgery. We also still do it keyhole, and we tighten the lower part of the food pipe so that the acid doesn't go up but allows food to come down. And usually such patients need follow-up, because if the acid continues burning the lower esophagus, the esophagus can narrow, and in rare situation there can be a risk of an early cancer forming. We call it Barrett's esophagus. The lining can change, and then later on it can go into a cancer. So she actually needs that condition addressed appropriately, and I would recommend she looks for a physician gastroenterologist to follow her up, and after some time, if they discuss, and in rare situation, if she's a good candidate for surgery, she could get also the surgery for tightening. Surgery for tightening is not the upfront treatment, but in some situation it might be recommended.
There are a few important points which we as doctors sometimes don't stress on as far as acid reflux is concerned. If you're a smoker, you should quit smoking.
Lifestyle.
Number one, if you're fond of heavy meals, you should take small, multiple meals. And if in the night,
in portions maybe?
In portions, you don't if you fill your stomach up, then everything will fill up.
Yes.
Third, if you are overweight, lose a few kgs, then you're almost surely this condition will improve. And finally, if you are sort of at the night time, if your symptoms are worse, you can have a head end of the bed raised a little bit while sleeping. So some of these simple measures can do the trick. And it's important that we sometimes as doctors don't emphasize so much on lifestyle modification, go straight to medical treatment, which is really should, as Dr. Kaisha said, not the upfront treatment, but right at the end of the line.
That's great. But I like also the approach, which is more on a preventive measure and making sure that people actually look into that. Evelyn, I hope your question has been answered, and of course, just getting a bit of more detail onto that. But gentlemen, thank you so much for being with us. But now as we come to a soft landing, Dr. Gupta, I just want to ask you, where do we take it from here? This is definitely a need that is in the country. You're here in the country. First of all, even just talk us through your diary. You know, are you going to be visiting hospital, maybe sharing ideas and sharing aspects in terms of just improving the general landscape?
I think I like traveling, and Kenya is a beautiful country, and people here are very, very friendly, and have had not only Dr. Kaisha, other students from here. It's a great time to catch up with them. As far as liver surgery is concerned, I think we've been, Dr. Kaisha and Dr. Kennedy and Dr. Julius, and we've been talking about this for a long time. And I think Dr. Kaisha is in a unique position now to take this forward here. And we will provide whatever help it needs in terms of training of people. Obviously, we cannot provide the money, but in terms of training, in terms of ensuring that the first 10 transplants that their team carries out will be successful. But quite often, I mean, I'm sad to say, it's much more in our country than, I don't know much about Kenya, but your own colleagues sometimes don't want you to progress rapidly. And sometimes they create hindrances rather than helping a new program to take off. So I think it's very important for a team which wants to embark on doing liver transplantation that they make sure all the other people who are involved in it get their due credit. Otherwise, it will start off, you'll name a lot of, you'll be on every TV panel and every show, and then it'll die down.
Do you mean like now several of Dr. Kaisha's colleagues like coming together?
No, in general, what tends to happen is the liver transplant surgeon gets a lot of publicity and name and fame, and you cannot do this liver transplant surgery without the support of everyone else. And then they start thinking that what's in it for me? Why am I helping? Why should I identify someone as being brain dead and motivate their family to donate organs when all the credit is going to Dr. Kaisha? So that's something that we've learned the hard way, that you ensure that everyone in the team is given credit, and and in fact the transplant surgeon stay in the background to ensure that this program is a big success.
Dr. Gupta, stay on to that thought. I think I have one of your colleagues who's on the line who's going to call us. I think he's a professor on the line. Prof, your question again to our panel.
Yeah, my name is Dr. Kakai.
Yes.
I'm working in Ikato University. I'm an immunologist.
Yes, Dr. Kakai, go ahead.
My question actually is the panelist. I want to know, especially from Dr. Kaisha, have we done any study to ascertain the instances of liver diseases, particularly those alcohol-related, hepatitis, primary biliary cirrhosis, or even cholangitis, so that we map out to see which benefits from this liver transplant? As you realize, we have had underfunding as far as study of this kind of disease is concerned. We doesn't even have the current, epidemiological survey, whether per county, how many people are suffering from liver disease, let's say in Nairobi, other than those who are coming in and being diagnosed from the hospital, environment. Don't you think it was necessary for us to do a national map out? We see how many will, have this liver disease, how many can benefit from transplant. Because when we talk about liver transplants, we need also to see who will benefit, and especially our laws, especially the deceased donor transplant. Our laws probably and our culture might clash. Thank you. I'm not professor, actually. I'm a doctor immunologist.
Okay. All right, Dr. Kai, thank you so much. Dr. Kaisha, that was directly to you.
Yes, thank you very much from Egerton. I don't have particular numbers offhand because, we don't have a good registry of diseases around the country. But what we know, and sitting next to the liver clinic, that just by looking at ratios of the patients who are there versus the rest of the patients seeking services in Kenyatta, the liver clinic and the surgical gastroenterology clinic is full of patients with a lot of liver diseases. Of course, his point is okay, and it's good from an epidemiologist angle that we probably need to document the disease burden that we have in the country, and doesn't really apply only for liver disease, it applies across the board, so that we can see how we can allocate resources. But let's remember, the person with that problem can't wait, needs treatment, and we know very well once you've reached towards the end stage of the liver disease, probably in 6 months' time, if you don't get a transplant, probably you die. You see, compared to end stage, for example, the stage 4 cancer, in some situation, probably very minimal can be done to prolong life. You are in palliative care. You can also be palliative care for end-stage liver disease, but there's a treatment that can actually give you life for a very long time. So we may not have exact figures, and this is something probably we hope was captured in the health bill, that requires that the ministry plus the counties keep a good register of diseases. If not, it's something we will follow up.
Thank you. Just to sample some of your comments online, thank you so much for those of us who are calling in. We appreciate the effort. And of course, I see some of us also tweeting at NTV Kenya with the hashtag AM Live TV, and I'm happy to ask the questions. I'm just trying to make sure that I can capture the ones directed to the doctors. But as you keep tweeting, allow me now to just kind of come back to you, Dr. Gupta. You called for a lot of collaboration. You called for a lot of interaction, especially amongst medics. Yes, it's true. And then, of course, with the line that it's liver transplant, and many people will be quite interested to follow up into how this will happen. Maybe if we could just learn, if maybe Kenyan doctors such as Kaisha can learn one bit from India, what would that be?
As far as liver transplantation is concerned, I think it's a teamwork. So alone you can do so little, and together we can do a lot. So I think the first and foremost thing that I would say is have a group of people, physicians, intensivists, radiologists, infection control people, all with you, supporting. Maybe perhaps you can call them for dinner once in a while to your house and establish links.
All right, that's great. I'm told we have another John on the line. All right, John, if you can hear us, your question to the panel, please.
Morning.
Good morning to you.
Yeah, my question is rather a little bit different from what you're discussing, but my wife always has some swollen legs during the evening after work. So we went to a certain doctor.
Yes.
So the issue of the liver came up. He gave us some medicines. We took some medicine, but the legs persist on swelling all the time. So is it possible she has a liver problem, or what is it?
Thank you, John. Dr. Gupta, what do you think?
Yeah, I think just from the face of it, there's one symptom that quite a lot of liver patients complain of in the beginning, that they just have what we call dependent edema, so that when they wake up in the morning, the swelling is gone, and as the day goes through, their leg swells a lot. But of course, there are many other causes of this, and some of the important ones I would first mention. One is varicose veins. So if you have deep vein thrombosis, then related to pregnancy, then you can have venous drainage of the legs, which is not right, so you can get swelling from there. You can have renal disease where the creatinine is high, or you can be on some of the side effects of drugs that you take for blood pressure. They end up with swelling. So it's really important. Leg swelling on its own can be from liver disease, but there are many other causes, and they must be ruled out before jumping to the conclusion that it is from liver disease.
But why is that? Maybe people would want to generalize, or is it really a fear that maybe perhaps, it might be a liver disease and people just attach these symptoms?
Strangely, I mean, my experience has been that most of these sort of leg swelling that has been present for a while is a marker of mild liver disease. Because one of the things that liver produces is albumin, and if the albumin is low, the albumin is a protein that helps to maintain and keep fluid within the blood vessels. And if the albumin is low, then the fluid tends to seep out. And so it is possible that she may be having liver disease.
All right. Dr. Kaisha, do you want to add on to that?
Yeah, what is imperative, because you see, we are just talking about one symptom. We have a chance to look at the patient and look at the tests. Again, I would encourage that person to really ensure that seen at least by a medical officer, or if possible get a physician who will go through all the possibilities. It's possible it can be liver disease, possible it can be something else, then offer them appropriate treatment or referral, because if the symptoms are not improving, then they probably need a bit more higher kind of care from a specialist or something like that.
I'm just looking at kind of the opportunities when you talk about collaborations. Where do you place insurance or medical schemes into that? Just before you answer that question, Evans Samto is on the line. Evans, your question to our doctors, please.
Yeah, morning.
Good morning, Evans, calling from Abuya. Please go ahead.
I was diagnosed with hepatic encephalopathy.
Pardon? Sorry, we didn't get that. Go ahead.
I was diagnosed with the hepatic encephalopathy.
Yes.
Yeah, it's the swelling of the liver, yeah?
Mm-hmm.
I don't know how I can go about the treatment because I've been so many tests, but up to now there is nothing much that have come to assist me.
All right, Evans, thank you for your question. And I just want to, Dr. Kaisha, if you could just quickly respond to that.
Indeed, if it's talking about encephalopathy, then definitely it's having some form of liver. The liver is failing one way or another. Hopefully, it's being seen by a liver physician, or it comes to the liver clinic in Kenyatta, whereby there are intermediate processes that can be done, looking at various exposures that he has, so that we can try and improve the liver function. But probably people with the encephalopathy in the face of liver disease like cirrhosis are probably heading the direction of transplant, because that really suggests that there's decompensation of the liver. Yeah, but Dr. Gupta, you can.
What he mentioned is actually that there's a kind of more of a swelling of the liver. Is that the first symptom? Or?
No. This is a condition which happens because liver is also a very important organ for detoxifying whatever sort of dangerous toxins that we ingest with food and drugs. And what happens in cirrhosis, typically, sometimes the blood will bypass the liver, because the blood, as you know, for the digestion process to take place, once the blood gets into the intestine, it has to go through the liver. So that all the stuff that you've eaten can then become part of your body. So when the liver becomes hard, this blood does not go back freely through the liver, and you form natural shunts, as we say. So that means the blood going to the intestine is bypassing the liver and going into the brain. And some of these toxins can then enter the brain, and you suffer from encephalopathy. Therefore, before you, of course, think of transplant, of course, is a good treatment for it. But there are many other ways you can minimize this. One is by making sure that you don't have constipation. That means you pass two stools every day. And there's a simple laxative that you can take ensure that. Of course, any small infections can precipitate this encephalopathy, to make sure that the food that you eat is well cooked, food that has been prepared in front of you, water that you drink is, so that infections risks are lower. And finally, there's a new medicine that we doctors use, which is an antibiotic that doesn't get into the system, but only works in the gut, so that you take that, then you will not have encephalopathy.
Thank you, Dr.
That's what I was saying. He needs to probably come to the liver clinic, where he can be given these therapies to try and manage the encephalopathy, as we try to see how much liver damage is there, and whether there are some reversible causes, or whether it can be stabilized so that it doesn't deteriorate. For example, if he's taking alcohol, he just needs to stop.
Okay.
Yeah.
Gotcha. I also want you to just talk a bit further on that ultrasound, like kind of just testing the liver, kind of the level at which the stiffness of the liver. We have another call on the line, please. Jeff. Joyce, I'm told. Joyce, your question to the panel, please.
Hello.
Hi, Joyce. If you can hear us, your question to the panel, please.
Okay, I have a question.
Yes.
My husband has hepatocellular carcinoma.
Go ahead.
And FEMA is 12 by 9 by 11. And he doesn't take alcohol. No, he doesn't smoke. And like you are just asking whether it can be done, if the tumor can be removed. He was done chemo, but the alpha-beta proteins they raised. The alpha-beta proteins were 28,000. it raised to 41,000 after chemo. Now he has been changed from chemo to Soravenib. Now we are wondering whether it can be done the section or what can be happened. Some people are suggesting we go to India for further management. I'm currently asking whether we can get and help, whether the tumor can be done section or we are medic. I'm a clinical officer, so being a medic with that condition is really an enabler to have.
Thank you, Joyce.
I don't know how can we help her, how the doctor can help her.
All right, I'll have the two doctors respond. I think by the end of the show, I'll have maybe a first-year degree in medicine, trying to really break down this kind of the technicalities. But I don't know, what would be your response to Joyce? And
Joyce, I think when you say chemo, did you have chemoembolization or was it chemotherapy? It was the two separate things. Chemotherapy just does not work in liver cancer. But chemoembolization, which is done angiographically, is very effective treatment. So if that has been done, and that can, for that to be done, of course, the bilirubin level in the blood should not be very high. It should be less than 3 usually. But it can be done, even if it's slightly higher, it can still be done. But so just try and check with your doctor whether chemoembolization is a possibility or not, because that is going to be the most effective line of treatment for your husband.
All right, Dr. Kaisha, can you respond quickly?
It also depends on whether the rest of the liver is functioning well or whether the function is not good. Because if it is functioning well, then still therapies can still be directed at the hepatocellular carcinoma. But if it is in the face or in the background of a failing liver, then the treatment would have to include thinking about transplantation.
Yeah, but the transplantation would not be a good idea for a tumor of this size, an alpha-fetoprotein of 22,000.
All right.
So first we will need to shrink the tumor.
All right. All right, we have another call on the line, and I think they're really coming thick and fast as we're nearing the end of the program. All right, Grace, your question to our doctors, please. Grace calling from Kitale, please, your question to the panel, please.
Habari ya leo.
Salama.
Nilikuwa na problem ya nilikuwa nimeshikwa kama kitu kama tonsils.
Aha.
Alafu sasa nikaenda treatment lakini sijapata change, lakini nasikia hapo kwa kifua katikati na numa. Alafu na kwa kifua inapanda juu. Sasa nimejaribu kutumia madawa lakini haipoi.
If I could get that's a condition of tonsillitis?
Yeah, she says she has respiratory kind of symptoms which are not going up despite, I think she sounds like she has self-medicated. So it's always advised to again find clinicians to look at you and treat you. I know we still have a lot of issues with health access and a lot of self-medication, which sometimes can be harmful. So I think the best advice there would be, again, to get a clinician to check her up and give her appropriate treatment for it.
And actually, I think Grace paints a picture of what is actually in the country right now. You'd find maybe people with conditions that they'll tend maybe to suppress it or still do not want to access medical assistance. But at the same time, also maybe get medical assistance, say, from the traditional doctors, for that matter, you know. And I don't know, Dr. Gupta, if it's something that also in India you'd experience.
Absolutely. I think by and large, at least in our country, there's great mistrust of doctors. And mainly that has stemmed because the government has not been able to build up a robust national health service and this national health service has nothing to do with the richness of the country. Cuba, which is one of the not a very well-off country, probably has one of the best health systems in the world. And we in India probably have, although we have good doctors, we have good hospitals, but we have the worst health, and I'm sure I'm going to be short for saying this, but we have the worst health system in the world. And as a result, the The reason why one became a doctor was to help others. But nowadays we find a great difficulty in that the doctors, they're much more likely to trust a quack or someone who has very little knowledge of medicine than a person who is well qualified and trained. And this is the reality that we live in nowadays, and it's really sad.
It's interesting that you mentioned that, because, you know, from out here you'd actually say anyone who's just looking towards medical attention, they're just going to India. But maybe it's the systems and the structures. Hasn't the government kind of looked at how to develop this niche kind of, I should say, a product? Because, you know, you're looking at medical tourism and all the people who are interested in coming over for treatment.
So, you see, there's health, the treatment, and there's a health service. Both are very different. And as far as the health service is concerned, we in India are not doing well at all. And,
what the average Kenyan doesn't know is mostly those good services are private sector services and not public health services. And you know, India is a population of about 1.2 billion. So actually the parameters of India are almost similar like Kenya. So there'll be a population which is actually almost excluded from health service, and there's a population that's getting first world service. So that's what we need to be careful about. It's not like, so it's the same, and I think the mistrust from doctors comes because the doctors most likely will tell you the truth. The other alternative people will tell you your problem is easy, take this, you'll be fine, and maybe charge you 500 shillings and see very cheap remedies, and then I didn't get well, he tried. But if you come to me, probably I will not treat you immediately, I'll send you to go and do maybe a CT scan. And you are brought up to believe the doctor should give you the diagnosis when you walk in and the treatment, and you go home. This man doesn't seem to know what he's doing. You come with a CT scan and I tell you, oh, maybe probably even I need to do maybe another test to be completely sure, and maybe at the end of the day I tell you, yes, you have this problem, and maybe there may not be much treatment about it. Then you see, we wasted our money, wasted our time, and so probably part of our work is to come and also need to educate the society, and probably maybe after the elections, however, you give us more time to talk to people to understand how the process of even getting a proper diagnosis and treatment and the whole process of health service, and also put pressure on the national government and the counties to actually develop a proper health service, so that at the minimum, if you are in Kajiado, in Narok, or in Turkana, or in Vihiga, you will have a minimal level of access of healthcare with a referral system. It shouldn't be a shoot and miss kind of situation as it is currently.
World over, and I mean, Dr. Gupta mentioned about India, we talk about Kenya, and we're not really entirely out of the woods yet. I mean, the health has been devolved, and you know, you look at all the calls actually calling from, everyone's from Abu, you have Grace from Kitale, and people who are really far fields from the capital, I should say, where maybe we have an improved healthcare system. So I'm just looking at, you know, what are some of the interventions that can be done, say even by the World Health Organization, to you know put this also as one of a priority item.
You know, the World Health Organization, and I think I remember that's an Abuja declaration, tried to suggest that to meet certain millennium goals, a certain percentage of the national budget was supposed to be dedicated to health service delivery, around 15%. We know very well since around 2002, when the Kenyan economy started expanding rapidly and more money is being collected in taxation, the allocation for healthcare has actually shrunk from about 8%, now it's close to 5%. So there's no way you're going to deliver a public healthcare system, because health is expensive, and health does not directly produce money, but health indirectly builds the nation. If you have your productive people at work who are kept there through preventive health, through treatment when they need it, then the country will grow. But as it is, the allocation will not go anywhere, as it were. Probably we need to do more advocacy and push more funds to healthcare, so that when a county hospital should have a minimal kind of, even if you say level 4, then a level 4 hospital in Vihiga, Turkana, Mombasa should have the same kind of service. But currently it is so different some level 4s are not suitable to be called level 2s.
All right. I'm just trying to get...
I just had one point here, which I think the government, the Ministry of Health, should lay down guidelines that what is the minimum that a doctor is expected to do in a particular situation. Because what has happened now is that litigation and in suing doctors is rampant. And as a result, as Dr. Kaisha was saying, somebody comes with an ultrasound scan. You know inside very well that not much can be done for this patient. But unless you do the ultrasound, CT scanning, PET scanning and MR scanning, and then at the end you say we cannot do anything. Obviously, everybody feels that they've been cheated. So if the government were to lay down guidelines for particular countries that somebody comes this much, this is done, that is good enough. You know, it does not have to be the best in the world. It has to be region and country and population specific.
All right. I'm just going to come back to you. We really appreciate your time, gentlemen. Dr. Kaisha, I'm going to come back to you. If somebody were to just narrow all this talk that we've had for the past hour and so, what should they remember from you even as we wrap up?
So we need to remember that the liver diseases are prevalent. There are treatments, various stages of treatment. For maybe the end stage could be liver transplantation at the very end of the chain of treatment. But we also need to remember a good number of situations are preventable. This vaccination for hepatitis B, this vaccination for hepatitis A, this hepatitis C, not a big epidemic in this country, but there's a good number of intravenous drug users where it has been identified who need also to be reached. And then alcohol, an important cause of liver disease, which is very prevalent in this country. We need to address it. So we look at the prevention arm, treatment, and then we are looking at developing capacities to give you all kinds of treatment. And then what we also need to appreciate that we need to go and see the right people for the correct advice. And the right person doesn't need necessarily to be in Kenya, can be beyond Kenya.
All right, such as Dr. Gupta in India.
Thank you.
Your closing remarks?
Thank you. So I think in the end, if you ask me to wrap up, I think some important points about organ donation I'd like to make, because I'm very passionate about transplantation. And most countries, organ donation, particularly young people who had a road traffic accident or someone who's bled inside the brain, these are people who are brain dead, and brain dead can be diagnosed very easily, very accurately, and I would motivate these people to come forward and donate the organs of their near and dear ones at least, so that many lives can be saved. For example, if someone who's brain dead can donate heart, 2 lungs, pancreas, liver, and that liver can actually be split into 2 and used in 2 patients, the 2 kidneys and intestine. So I think I would like to stress that we should use this opportunity to educate people about organ donation.
All right.